I'm Brad Thrasher. I'm one of the pediatric endocrinologists. Thank you all for being here and allowing me to crash your kind of resident noon conference. We're going to be talking kind of just about improving the safety of insulin administration in the hospital. I'm a pretty laid back guy, so if you have questions as we go, please feel free to ask or anything like that, because I'm hopeful that we'll all be better when we're done with this talk today. All right, so the title, just improving safety of insulin administration. Accidents happen more than they should, and we'll give some history of where we're at right now. I have nothing to disclose. And then learning objectives, we're going to identify the common errors related to insulin use in hospitalized patients, provide an overview of ways to hopefully reduce those errors, and then review the policies specific at Norton Children's Hospital that we have in place that try to help prevent and reduce errors as well. So medication errors, I'll say when you start looking just at medication errors, there's no like one unified definition to define what a medication error is. What you see on the screen here is a definition from the National Coordinating Council for Medication Error Reporting and Prevention. That is a big group to be a part of, I guess. But I think the takeaway from their definition is that medication errors are preventable. And they typically lead to inappropriate medication use or patient harm. And there are ample opportunities for medication errors to occur anywhere. It's not only prescribing and administration of the drug, it's the making of the drug, the product labeling of the drug. They have on here, monitoring of medications and even education pertaining to medication. So again, lots of opportunity for errors to occur when we're talking about medications. And in the United States, there's approximately 6,800 prescription drugs that are available, and just countless over-the-counter herbs, vitamins, supplements. Annually, about 7 million people are impacted with medication errors in hospital settings. And of this 7 million, 7,000 to 9,000 have fatal outcomes, which is wild to think here we are in 2024 still with errors, happening that lead to death. There's a huge cost associated with medication errors to the hospital systems. It's estimated $40 billion a year. And not only is there a huge cost that's associated with it, it's also detrimental to the healthcare community too, because we're losing our patients' trust with each medication error that, goes into the news or is making headlines. And it also causes, physical harm potentially to patients and psychological detriments as well. So it's not just money related. There's, just a lot of other things that we could prevent as well, if we could prevent errors. When it comes to just types of errors, this pie chart looks at just 10 of the most common types, with omission and improper dose being the most common. We're here to talk about insulin today, and omission and improper dosing of insulin are the most common types of insulin errors that are associated within the hospitals. Unauthorized drugs, that's 17%. I'll be honest, I had to look that up because, like, what does that even mean? Unauthorized drug use is like when a medication is given, but it wasn't prescribed by a prescriber. Or let's say you prescribe a drug and you put parameters in there. So like, say we're dealing with insulin and we use a sliding scale. We don't use sliding scales here, but some hospitals do. And a sliding scale, if the blood sugar is between 150 and 200, give 2 units of insulin. Well, somebody might read that and say, oh, the blood sugar is 130 and still give 2 units of insulin. That would be an example of an unauthorized drug because those parameters weren't met. Wrong patient can also fall on that. They kind of separated that out just because 5% of patients in the hospital system are still given the wrong medication, which again is wild with just, the way that we have barcodes and hopefully like 2-person verification. But, there's a lot of hospitals in America. Errors still unfortunately happen because people get tired. We're not perfect. And we can all think at times we're probably overworked and just trying to rush to get things done. And that's typically when these type of errors occur. So like I said, we're here to talk about insulin specifically today. And when insulin is mentioned with medication errors, it's typically in the top 5 of all medications reported in America that are associated with insulin. Here on this list, I'm showing you that it is actually number 5. Insulin is known to be a high-risk medication as well. And a high alert medication is any drug that bears a heightened risk of causing significant patient harm when used in error. And with insulin, it's a fine line that we walk, because if we don't give enough, we can cause hyperglycemia, potentially even DKA if we omit or hold that dose. And if we give too much, we can cause, seizure, coma, and death. So it's a fine line that we walk. In terms of medication errors that are lethal, insulin ranks number 2 on that list. This is another interesting fact of medication errors that result in death within 48 hours. 33% of those deaths are related to insulin. Big number, which is just crazy. This is a study that was done looking at just insulin administration errors from 2010 to roughly 2020. And I just think there's a lot of interesting facts here. So 2/5 of people taking insulin, where they have type 1, type 2, and MODY needing insulin, when they're admitted to the hospital, report having an error associated with their stay. I mean, that's 40%. That's a huge number. And then this particular paper looked at type 1 and type 2s on insulin and the type 2s that were not on insulin, and kind of broke down just where errors have happened at. So kind of the left side of the screen is the type 1, of course, they're on insulin, and type 2 on insulin. And what you can see is in 2010, approximately 55% of those admitted to the hospital had some type of medication error reported. In 2013, hospitals were a little better. We dropped that to the mid 40s. But then back in 15, we were up again to the upper 40s. And then since 2017, it's been hanging in the low 40s. And even the most recent data is around 40% looking at errors. And again, it's a huge number. Like if you was to tell me 40% of airplanes are going to crash that take off today, I would really consider going to the airport. Like I can guarantee you I would drive a lot more. And I got 4 kids that scream and cry a lot. Flying's great, but if we're going to die, probably not going to do it. And I'd even be willing to bet money that if these kind of numbers, like if the common public knew that, man, if I go into the hospital and I'm on insulin, I have, a 40% chance of error happening, they probably would really think twice about, man, do I need to go to the hospital or not? So I think, this data shows us, yes, there's problems, but man, there's a lot of opportunities here that we can improve, as just a healthcare system, nationwide. And we also have, improvements here that we can make in our own healthcare system. So just some fun headlines over the last 3 years regarding insulin error. So the first one here, Pennsylvania nurse accused of killing 2 patients, injuring another with insulin injection. This happened last year. She was a geriatric nurse who has been accused of what you see in the headline. Her case is still ongoing. It's actually a very sad case. When you dive into it deeper, she has admitted to harming other patients at other facilities. So now the total is up to 19 people in total. So her case is still ongoing. It's in the news. It was recently, just last month, making headlines again with her admission of other victims. So wild that she had no overchecks there. Our neighboring state, Indiana, this was from a few years ago. 16 Indiana students hospitalized after getting shot with insulin by mistake. They were supposed to be having a TB test done at their school, and somehow insulin was put into the syringes, and 16 kids had insulin injected into their skin. They were all okay. No harm was done, but still, how does that happen? It did not that long ago. We're talking 2020s here. This is crazy. More than 260,000 diabetes inpatients had hospital medication errors in 2017. This was a paper that came out of the UK. So our problem's not only in America, is what I'm trying to show. Like this is a, global problem that forget what hospital this was, but it's based out of London. But they even reported of the 260, approximately 10,000 had a significant hypoglycemic event of where they were either administered glucagon or required, IV dextrose to help out. And then insulin errors potentially plague hospitals treating diabetes patients. And this was a paper that was in the news about 2 years ago, and it was looking at the VA system specifically in Pennsylvania. And the journalist that dove into it kind of reported that the amount of errors pertaining to insulin had increased by approximately 30% from the late 90s to the mid 2000s, which again, wild, we're getting kind of worse there instead of better. So types and causes of insulin errors. So like I mentioned earlier, omitted and delayed insulin is the most common that we see in the hospital settings. And, as we go through kind of the bullet points here, they're easy to happen. So insulin not prescribed on hospital admission or transfer. I mean, this one's relatively easy to think of. Like a kid comes into the ER, they're on a multi-dose insulin regimen. They typically get their Lantus, at dinner time. They show up because they injured themselves. So they have, gastroenteritis. They don't get their Lantus because mom and dad didn't give it before they showed up. They don't get it in the ER. They get admitted to the hospital. There's poor communication. The admitted team thinks, oh, they normally get it at night. They must have got it. And then they're admitted to the floor. No Lantus was ever given. They've just been getting short-acting insulin. And we're like, man, why are their blood sugars high? Like, this has happened. Tristan's smiling in the background because he's seen it. But that happens at every hospital I've been at. Like, that's just an easy example of how that happens because we go too fast sometimes because we're, a lot of times it happens more at night because the call coverage is less and we're just trying to get things done. So again, if we could just slow down and have a little better communication, just asking a few more questions, we could prevent that potential error. Prescribed insulin product not available in the clinical area or following discharge. So, our hospital, we have a set formulary. Our short-acting insulin is typically Humalog, but some kid might be on Apidra. They come in, they tell you, oh, I take Apidra. You're going through the list. You're like, well, I don't see Apidra here. You can click, oh, here's the long-acting. And you say, well, Lord, I'm busy. I'll ask somebody later and I'll come back to the short-acting. And then we never order it. And then the kid gets to the floor, they eat, and then they're not giving, mealtime insulin beforehand. An error just occurred because we didn't order what the kid needed, because we didn't make the connection that, oh my God, they're on Apidra, we can give them Humalog and they'll be A-okay. Confusion over insulin dose administration when patients are NPO happens all the time, not only in the hospitals, but at homes as well. Those of us that work with endocrinology, heck, you guys probably too, have seen kids admitted in DKA that, they get sick, mom and dad hold their dose of Lantus because they think, oh, they're not eating, they're throwing up. And then they go into DK later in the day because they held the dose. You could say, man, is that an error in education because the family didn't know what to do? Is it an error in our nurse system? Because there's been hospitals where nurses have held the long-acting dose because the patient's NPO, because they're not going to eat, they'll be okay. So again, a lot of this can go to education. Insulin dose not administered at the appropriate time to the administration of food. Again, this is one that happens in hospital systems every day across America. I'll say here, I think we do a really good job of trying to make sure the dose is given very close to the food. Our nurses try to be within 30 minutes of making sure that when the kid eats, they're getting insulin. But I know that's in some adult hospitals that I've had a friend admitted to an adult hospital with diabetes, and they checked their blood sugar, they gave them food, and then nobody came back to about an hour and 45 minutes later saying, here's your shot of insulin. We're delayed. A lot has changed during that time frame. Again, happens every day. And then I'll blame the pharmaceutical companies a little bit for errors because everything is named very similar to one another, and it can get very, very confusing. So some examples, Lantus and Lente. Lantus is long-acting insulin, it's glargine, right? Lente, it's an intermediate acting insulin. We really don't use it that much anymore, but it's still out there. And there were lots of errors regarding these two when Lantus hit the market, in the late 90s, early 2000s. Humalog and Humulin. Does anybody in the room know the difference between those two? No. So, I mean, Humalog, it's Lispro. It's our rapid acting insulin. Humulin is still a short acting insulin, but you can have Humulin R, which is regular insulin. You can have Humulin N, which is NPH. So again, why do they make these names so similar? I don't know. Part of me thinks that they were just trying to create some errors for us. Glucine or glulicine and glargine. Does anybody know glulicine besides? No? All right, it's Apidra. So it's a short acting insulin. But it's very similar again here to Lantus. Like Apidra is not really used here. It's not on our formulary, but when there's rapid acting insulins, I mean, we have Lispro, or I'll give you the kind of brand names: Humalog, Novolog, Apidra. There's Admelog. God, there's even more on the market now that I'm forgetting. Say it again. Lumjev. Every year there's kind of more and more because we're getting more of these generics kind of hitting the market. And then Humalog and Humalog mix. So just to make your life even more fun, you can have regular Humalog, or you can mix Humalog with NPH and get a mixture that has been used in people as well. So yeah, fun time. So you got to know what you're ordering because the onset of action, the peak, and the duration of action is very different in these drugs, and it can have lasting effects. You know, before patients go home, they always go home on, multi-daily injections. We really stress to them, like, what is your long acting versus what is your short acting? Because if you're giving long acting for meals, we're going to have lows. And every year there's a patient or two that will, mix up their Lantus with their short acting because mom and dad are in a hurry. So like it still even happens under the best of circumstances. Other types of errors that can occur pertaining to insulin, just improper patient monitoring. Patients on insulin, they get admitted to the hospital. We're not ordering blood sugar checks, or we order one check a day. It's not going to cut it. Like, insulin is this high risk medication. We talk about this fine line that we have to walk with the highs and lows. It requires frequent monitoring to keep these people, to keep them safe. Poor coordination of blood glucose testing with insulin administration at mealtimes. Again, we've kind of already covered that one, but again, we just want to make sure that when we're eating, we're taking insulin in an ideal world 10 to 15 minutes beforehand. We do it a little bit differently in kids that are transitioning from DKA. We'll dose after they eat because again, we don't know how much they're going to eat. We're trying to have them not go low, but once they get to the floor, if they're an older kid, we're trying to dose before they eat, just because insulin's going to have better action for us if we're dosing before. Incorrect use of insulin delivery devices. I smile at this one because there's been a lot of technology that's come to play in the last decade, and people will get, CGMs and insulin pumps confused. I've been told, oh, they're on a pump, and then I go see the patient and they're not on a pump, they're on a CGM. And that CGM doesn't deliver insulin, it's just checking what your blood sugar is. So, again, I think that just goes to more education is needed on what technologies we're using and understanding these technologies. Wrong route of administration, IM versus sub-Q. The way that the insulin is designed is to be given sub-Q. If you give it IM, it's just absorbed much faster. So you run the risk of lows. It's guaranteed to pretty much happen if you give it IM. And then again, another just poor communication. And, I don't think I can stress just how much effective communication can go in preventing insulin errors. So, during these patient transfers, where they're coming out of the ER or they're coming, out of the ICU, kind of asking, what is their insulin plan? When did they, if they're on shots, when did they last get Lantus? Did they get Lantus while they were in the ER? When did they last get their last short-acting dose for their correction? When did they last eat? Just understanding all these little things so that we can keep the patient safer. Oh, there was one thing I wanted to show on here. There was a study with the insulin administration at meal times, and there was a hospital that put into play. They wanted insulin to be given within 15 minutes of eating, and they did all this education. They kind of got everybody on board, and even with the best of education, only about half of the patients received insulin within the allotted time frames that they were going for. Just because again, people are busy. This is hard to stick to it. So we want to do our best. But yeah, I thought that was just kind of interesting that even training people, we still had issues with it. So what can happen? So it's this fine line that we walk. So if we give too much, seizure, coma, death. Nobody wants that, period. If we don't give enough, we can lead to hyperglycemia, and then potentially DKA can occur. Let's say it's not recognized, cerebral edema, potentially death that way as well. I pray that would never happen. But again, it's we're dealing with a high risk medication here. And then again, I just threw in here again that little fun fact: 33% of errors that are due to medication errors that lead to death within 48 hours are insulin related. Huge number. And when medication errors pertaining to insulin occur in the hospital eats a lot of this cost now too, because the Center for Medicare and Medicaid Services, who reimburse our government insurances, say that if a patient has severe hypoglycemia or hyperglycemia while they're hospitalized, it's preventable, it shouldn't have occurred, and we're not going to pay for it. So any patient that goes into a hypoglycemic coma or they slip into DKA while they were in the hospital, it's on the hospital. So ways to reduce errors. So one is just, prescribing insulin. So First way is just consult endocrinology. You know, I think we do a really good job here of every patient that's prescribed insulin, type 1, type 2, MODY, what have you. I feel like, you know, endocrinology gets consulted on those patients to help out as we can. So I think we do really well here with that. Document the indication for insulin use. You know, like if a kid's coming in and they broke their leg, but they have, you know, type 1 diabetes, you know, it needs to be in the chart. They have type 1 diabetes. And this is why we're prescribing insulin. Because again, it's just good communication amongst the team. Because I know that our pharmacy friends, when insulin is prescribed, a lot of times they'll read notes to find out why in the world is insulin being prescribed. And when you say type 1, well, there we have our answer and we can move on. Develop and utilize insulin order sets. And this is huge because insulin order sets have been shown to not only prevent medication errors, but they've also been shown to improve efficiency and improve workflows in hospital systems. Because basically they put a standardization to it that just makes life a little bit easier and safer. And so some of the guidelines that pertain, like where should these order sets be at? When you're transitioning from IV to sub-Q insulin, like let's have an order set for that when we're coming out of DK, just to kind of help everybody out. The order sets too, a good order set is going to define, you know, what our doses are. It's going to spell out there, you know, what's our insulin to carb ratios, you know, what's our correction factors, what blood sugars target are we aiming for? So again, it's just good, easy, laid out communication. A good order set's not using abbreviations, you know, it's kind of spelling it out so everybody's on board as to what is happening. The laboratory testing and the monitoring practices, again, you know, if we have somebody on insulin and we don't order, you know, blood glucose checks, we're failing that patient. So an order set should have in there how often to check blood sugars, what to do if a blood sugar is outside of a certain parameter, meaning if it's low or if it's high. Are there other laboratory tests that we need to be getting on these patients as well? And then again, communication and management of abnormal blood sugars that are outside of what we're going to deem normal ranges. And then if a patient does have a hypoglycemic event, that order set should go ahead and have all the orders needed for medications, whether it's glucagon or if we're doing simple sugars, like it all should be there. So the nurse has it available and she's not trying to page, or, you know, the resident or the attending, be like, I need orders because this kid, you know, blood sugar is 38, he's unconscious. Like it needs to be fast. And then the order sets too, like other ways to reduce it is having policies in hospital systems pertaining to insulin pumps and CGMs, because technology is our future. It's changing. Heck, I'll say it's revolutionizing diabetes care in terms of our smart pumps and things like that. So, you know, we need to have policies in place and how we're going to use the technology when it's here. I mentioned this earlier, like we're not using abbreviations. It's just clear cut communication. And one of the things that we've been working on as a group too is even verbal communication. Instead of saying, you know, BG target, we're trying to say blood glucose target, or instead of saying, you know, CF, say correction factor is whatever at this time, just so everybody's on board. And I think too, when it comes to communication, asking to repeat back, or if somebody doesn't ask to repeat back, to say, hey, can I repeat it back to you just to make sure I heard you correctly? Because, you know, it is, as we're learning and we're going, you know, unfortunately, there are mistakes that happen with even putting stuff in an insulin order set. Like it wasn't too long ago, there was an insulin order for an insulin to carb ratio of 1-to-1. I mean, that is a profoundly strong insulin to carb ratio. Like I'll say, I've never seen a kid that needs a 1-to-1 ratio. But yet it was caught and there was no, you know, error that happened with it. But I think that if you understand like how insulin works, like we probably wouldn't type 1-to-1, you know, if we had just some better education with that. And then again, just communicate with all team members, because sometimes we have new interns, we have new nurses. My wife's a nurse, and I've asked her, like, what education did you get regarding diabetes when you were going through training? And yeah, it's none, you know. She's like, it was very limited. It was like, you know, if you had a patient with it, we got a little bit, but, you know, she's like, I was always nervous taking care of patients with diabetes because I didn't have a solid background into what to do. So I think it's just, you know, if we, you know, take that time to be like, this is our plan. Do you have any questions that I can help answer, to just to make sure we're all on board? And then our pharmacy helps to reduce errors as well. They have processes in place to differentiate the insulin products, you know, as to where we're storing the long acting, where we're storing, you know, the rapid acting insulin. Like I said, our pharmacies here, I think, do a really good job of confirming the doses. I've gotten several phone calls, and I know my colleagues have gotten phone calls too. Hey, I read through the notes. This was the dose in the last note, but now we've ordered it this way. Why? And I think that's always a good question to ask because, again, we're just having open communication as to what's changed. Um, and then insulin pen vials, when they're on the units, they need to be specifically labeled to that patient. So here we put barcodes on that particular pen. So before the insulin is administered, the patient scan, the barcode scan, they're making sure they're lining up with one another. And then we even do a two-person verification when it comes to dosing in our hospital system, meaning two nurses have verified that this is the appropriate dose, just as ways to keep people safe. And then administration and monitoring of insulin. So again, we talked about the pins here. They have barcodes because there have been reports of a pin would be on the floor. One nurse grabbed it for patient A and then put it back in, and then another nurse grabs it and gives it to patient B. That is a huge error right there because we're sharing potential drugs, and if they didn't change the needle, I mean, it can get into a whole can of worms real fast. And then using coordinated process to ensure timely blood glucose check. So again, I put that one in here 3 times because it happens a lot more, I feel like, at adult hospital than it does in pediatric hospitals, and talking to my friends across the country. But again, I just want to make sure that we continue to do a good job of just making sure, like, if a kid's on insulin, make sure that we're putting those orders in so they can check the blood sugars and give them insulin in the appropriate time frame. So we're not having a kid sit on the floor for hours not being able to eat, or the potential error occurs of where mom and dad get frustrated that nothing's been put in the system and they go to Chick-fil-A or Subway and they buy food, come up and just give the kid to eat and say, I'm tired of him screaming because he wanted food, and then we didn't dose for it. And then document all point of care blood glucose values, because again, this lets us know how the patients are doing. It allows the team to make better changes to their dosing regimen. It keeps us all safe. And then at the time of administration, I kind of like a lot of these lines here of just kind of talking out loud, because people that use insulin, they know their doses and they can do their calculations pretty fast, especially they've been on it for a while. And so if in the room, if the nurse says, a lot of times we have our shape sheets, y'all have all seen those. A lot of times, all the carb ratios, the correction factors on the board. A lot of times the nurse is working with the family with the shape sheet to do the calculations, and they're verbalizing everything out loud, which is great. But there could potentially be a chance of where somebody did math wrong in their head and they get 10 and somebody else gets 8, and it gives the opportunity to say, hey, let's talk about as to why we're getting different numbers here. So hopefully it prevents an error and allows, for education to occur at the same time. And just always informing the patient, what we're giving, again, I think can reduce error too, and the dose that we're giving. And safe transition to care. And this slide here is pertaining more to going home, like, you've just been diagnosed or you've been in the hospital and you're leaving, and the family is going to be in charge of managing the kids, diabetes and insulin regimen. And our educators, they're sitting in the back, they do a real good job of hitting this stuff with the family, because a lot of it's about education. The families have to show us that they know how to check blood sugars, that they can do it. They can check multiple times a day. They can tell us the differences between short-acting insulin and long-acting insulin. They can tell us like what the dose of long-acting insulin is. They can do the short-acting insulin calculations when it comes to, counting carbs in foods, using the ratios to determine how much insulin should be given before meals, knowing what to do if the blood sugar is high and how to use correction factors to, give extra insulin when needed, verbalizing signs and symptoms of, hypoglycemia, how to treat hypoglycemia, if it occurs, whether it's just giving simple carbohydrate, a 15-gram snack, and rechecking 15 minutes later, or, worst case scenario, patient's unconscious and we're having to give glucagon. Like, we try to educate, or we do educate families and all those matters so that they can be set up for success, when they go home. A lot of times, I'll tell families, we're going to give you a foundation to keep your kids safe that we're going to just be continuing to build on for years. And then, when they go home, make sure they have all their supplies. Like our pharmacy team, I think, does a good job of delivering the meds. Most of the insurances that we deal with allow for our pharmacy to fill. It gets delivered, either the educated or the nurses. A lot of times we'll go through to make sure they have all their supplies and their insulin, because we don't want a kid to go home and all of a sudden they don't have their mealtime insulin, and then we're trying to send them to another pharmacy to find that. So we do a good job with that. And then we've got to make sure that they have follow-up because, kids they're growing, they're changing. Whatever we put in place, especially if it's a new onset, is going to change in terms of insulin regimen. It's not like they have strep throat and it's, take this, here's your amoxicillin dose for the next 10 days. Like it's dynamic, it changes. So typically we'll see a family within approximately 2 weeks on the outpatient side of things. And then once they're in their routine, every 3 months, they're coming to see us just to kind of see how they're doing. And then we have a large team of educators where a lot of families are sending in numbers monthly, if not sooner, just, hey, can you review these numbers and see what changes need to be made so that we can keep them, safe, healthy, all at the same time. So order sets are important. Like I think that our team has done a great job doing order sets. Tristan, Kirsten, and Heidi have all worked hard over the years at developing order sets. So this slide's kind of a repeat of last slide, but I just wanted to just make the statement like we have order sets for when you're admitting somebody to the hospital on how to administer insulin. We have order sets when you're transitioning, from the PICU to the floor of how to transition from, IV insulin to subcutaneous insulin. Then we now have surgical order sets. We have discharge order sets. So we've tried to, simplify it, improve that workflow, and reduce medication errors all at the same time. And now the kind of the next part of the presentation is going to be kind of working through all these order sets as to what they mean. But before we get there, I got to give y'all a joke. So when I told people I was moving to Kentucky, one of my friends sent me this joke. I'll just read out loud. A nurse caring for a man from Kentucky asked, "So how's your breakfast this morning?" "It's very good, except for the Kentucky jelly. I can't seem to get used to the taste," the patient replied. The nurse asked to see the jelly, and the man pointed at the bedside table. "Oh yeah, it's a full packet labeled KY jelly." So welcome to Kentucky, was what my people were telling me when I said I was going to move here. So I've yet to see this happen, but I think I've met people that it could happen in. So we'll see. All right, so our order sets here. I know that it's tough to see on the screen. I was wishing it was bigger, but the things that I want to point out is that with our order sets, the things that kind of the safety corporations have talked about on what we just reviewed, we've incorporated pretty much all of that into our order set. So starting off, the order set is when to notify the house officer. Basically, the parameters that we're trying to blood sugars here are 70 to 300. If they're less than 70, the house officer gets notified. If they're over 300, the house officer is getting notified of those blood sugars. Not only are we checking blood sugars in our hospital, we're also checking ketones in our hospital as well. Because a lot of people get so concerned over a blood sugar of 500. Yeah, it's a high blood sugar, but when you tell me blood sugar is 500, my follow-up question is, what are the ketones? Because if you're 500 with no ketones, that's very different than if you're 500 with large ketones and throwing up. So our order set has, while the patient is in the hospital, just every void checking ketones. Because a lot of times they're sick, and when you're sick, you typically make ketones and it increases our resistance and things like that. So again, we're trying to prevent kids going to DKA once they're on the floor. So we are checking for ketones every void. What you see here is how to handle those ketones. So we use, if you're small, moderate, or large, it's a dosing based off of percentage of your basal insulin. And I'm going to come to that in a minute. So I'm going to skip that for now. But what this spells out for you here is, let's say you have moderate ketones, but your blood sugar is 103. That's a different story than if your blood sugars are, 400. Because if you give insulin for ketone dose of 103, you're probably going to have that kid go low. So this section right here kind of spells out of our number that we use is 200. If you have ketones with over 200, you're safe to give that correction dose and proceed. If it's less than 200, it's called the endocrinologist on call so we can discuss more about it and come up with a plan as to what to do. So again, we've given parameters as we're checking, we're monitoring, we're keeping people safe, and we got actions in place as to what to do for different outcomes. The next little section breaks down, if we're eating and not eating. So basically, if they're eating, we're checking blood sugars before each meal, bedtime, and O200. If for whatever reason they get made NPO, they go to Q4-hour blood sugar checks and get corrections as needed. And that's all kind of built into right here. And then this section here talks about transitioning. When the kid's coming out of DKA, we give Lantus, because that's what we typically give Lantus. Our formulary also has Tresiba and Levemir as well, but we typically give Lantus. And then we leave the drip running for 2 more hours just because the pharmacokinetics of how Lantus works. And then after the 2-hour mark, the drip stopped, and then, the patients, typically transition to the floor at that time. But that's all spelled out right here. It's exactly how to transition that kid from the drip to subcutaneous insulin. This is kind of for nursing and for residents as well. It's just signs and symptoms of hypoglycemia, what you may encounter if a kid's blood sugar is, less than 70. And then right under that is how to treat hypoglycemia. So, we have parameters in place for if the kid's alert, able to tolerate PO, give them some simple sugars. It talks about crackers or juice boxes, all the stuff which is, on our floors that our nurses have access to. And then the next set for hypoglycemia is this worst case scenario. If they're unconscious, of giving glucagon and how to give it. So, we're checking all this when it comes in so that we're prepared for, worst case scenario there if need be. And then the next sections are labs. Again, of how frequent we were checking the blood sugars and the ketones. So we're always checking those. You also see RFP, the renal function panel. And I just wanted to bring this to you guys' attention because a lot of times we continue to order that when we don't need to. So we put this order in here to say, keep measuring keep obtaining RFP to measure the bicarb until it's 20 or more, just because we don't want people to slide back in decay. We're transitioning a lot of times people around 18 on it. We will make sure they continue to progress and don't go backwards. But a lot of times, kids will sit in the ICU, the bicarb's 23, we're good. The next check, is 24. But then when we're ordering, we continue to click this box. You don't have to, because the order doesn't automatically remove it when the bicarb's greater than 20. It's there for if it's less than 20, let's keep checking every 4 hours until we're greater than 20. So if you have a kid that you're, bringing to the floor whose bicarb greater than 20, you do not have to check that one. You can save the kid potentially some money and a poke. And then the other labs are in here for as well, mainly a new onset. So we're looking at, the common diabetes and our autoantibodies associated with diabetes. We know if you have one autoimmune disease, you're at risk for others. Living with type 1, you're more at risk for thyroid and celiac. We screen those at diagnosis, and we catch a fair number of kids every year that I'm going to say thyroid is more prevalent than celiac, but we do find some kids at diagnosis with celiac as well. So that's why we have those in there. If somebody was to ask, well, is when a kid's in DK, is that the best time to get thyroid function test? The answer is no. Because of just the metabolic, just dysfunction that I can say you in. Typically, we do get some abnormal TSH levels, but we're drawing labs. It's a good time to get, and we still get a fair number that are normal. But if we have one that's abnormal, a lot of times we'll just repeat it when the kid's out of DK and they're just fine. And then we have our consults, to endocrinology. So again, we can help out with prescription or prescribing the doses and managing, their diabetes, especially if they're a new onset coming into the ICU in DKA. And then here we have their medications. Again, we have glucose, glucagon, IV versus IM for worst case scenario. If they're not eating and they're going to be on fluids, you have fluid selections, or if they're just severely dehydrated, from they had mixed DKHHS, they might need fluids for a little bit while longer. So we can, keep fluids going and just an easy check here. But then kind of the meat is when we get to insulin and what are we clicking, how are we getting these doses, and what are we doing? So this is an order set, not for pumps. This is for multi-daily insulin. So right here, it's telling you your total daily dose, 0.3 to 1 units per kg per day. So when we calculate doses for kids, it's all weight-based. And basically, we take their weight. If they're an older kid in puberty, we're going to be closer to 1. If it's a younger kid, not in puberty, we're going to be, closer to the 0.3, 0.5 units per kg per day. First, this talk's not to tell you how to do insulin dosing, but just quickly, about half of that dose tends to be long-acting, and the other half of that tends to be our coverage for our meals and corrections. So this is kind of breaking it down to our long-acting insulin and our rapid-acting insulin. So here in our hospital, for our long-acting choices, we have Lantus, Levemir, and Tresiba. Levemir will be disappearing because Novo Nordisk has announced that they will no longer be making because they're not making money on it. So by the end of this year, Levemir will be no more. And I guess we'll be with Lantus and Tresiba. Both are fine, long-acting drugs. You know, we have the box checked, and it's telling you right here that these are 24-hour drugs. You know, we're giving it 1 time a day. And then here, Lispro, this is a short-acting drug, and you know, you can click it, and then it's going to populate to another box that's, you know, your breakfast, your lunch, your dinner, and all that jazz. And then, just for the confusing names, we do have other rapid-acting drugs, you know, on formulary here. So we still have NPH because, you know, the vast majority of kids don't use NPH. You know, we've had discussion like, should we take this off our order set because we really don't use it a lot? Well, there are some kids, you know, CFRD is probably the best example I can give, that, you know, they're on tube feeds overnight. They have hyperglycemia during that time. They don't need insulin necessarily during the day. It's just that continuous infusion of glucose. They might need a little regular insulin or a little NPH just to kind of cover during that time. So it's not frequent, but we still have a few patients that do use these older insulins, if you will, and that's why they've still been left in the order set. But we, like I said, we have NPH, we have regular insulin, we have Humalog, and we even have, I think, the Humalog mix in our system too. Is that right, Tristan? Oh, it's gone. Okay. All right, it's gone. So don't worry about that one anymore. And then the next one is just our ketone supplementation. So ketones, again, we base the dosing off a percentage of your long-acting, your basal insulin, but we're not giving you extra long-acting insulin for ketones. We're giving you extra short-acting insulin for ketones. And this spells out how we're doing it. Small ketones are 10% of your total basal dose, 15% of your basal, and then 20% of your basal. So when you click this, this is what you guys see of how to order it, right? And there's a lot of words here. So you have blood sugar target, thresholds, correction factor, insulin to carb ratios at all these different times. So what do all these mean? So our target, this is just where we're aiming to keep the kids' blood sugar. I try to tell families, you know, we're dealing with diabetes. It's unrealistic to think we're going to keep a kid's blood sugar 120 all day long. There's going to be, you know, variations to that. But this is just when a kid's blood sugar, or when, let's say we're having hyperglycemia, what are we trying to correct their blood sugar down to? That's the target that we're aiming for. And older kids will go with a lower target, 120, 110. A littler kid, the target's going to be higher, you know, 150, 160. Because in those littler kids, we're trying to prevent hypoglycemia, especially if they can't communicate as effectively as older kids. So the target is just what we're aiming to be, what we're shooting you to get down to when you're running high. So typically, most targets here are about 120 when y'all are calling us for orders on kids. Threshold. I know this one can be confusing. Typically, the threshold is the blood glucose target. Typically, they're the same thing. But there are some situations of where we might set a target at 150, but a threshold at 200. And what that means is we're not going to start giving extra insulin for corrections until they have exceeded that threshold of 200. So it's a way to try to prevent hypoglycemia in some people. Typically, it's younger kids. Like you might have a target of 150 in a kid, but if their blood sugar is 185 and you give a half unit of insulin, it, you know, makes them go low. So we might say, okay, well, we're going to keep your target at 150 because that's what we want to be aiming to for 300, but we're not going to give you any extra insulin until you're above 200. Does that make sense? Okay. So correction factor, how many points the blood glucose will drop with 1 unit of insulin? So just how can we bring you down? How much insulin do we need to give you to bring you to that target blood sugar? And then how to use a correction factor. So basically, you're just going to subtract your target blood sugar from your current blood sugar, and you're going to divide by the correction factor. So there's our formula right there. Insulin to carb ratio. How many grams of carbohydrates are covered by 1 unit of insulin? So the number of carbs you eat, we have the patient calculate that up, and then it's just divided by the ratio. So if they eat 60 grams of carbs, their insulin to carbohydrate ratio is 1 unit of insulin per every 10 grams of carbohydrates. You divide by 10, and they're going to get 6 units of insulin for that meal that they just ate. And then again, just going over ketone dosing. Ketones require extra insulin because they're increasing the resistance in the body. So we're giving extra insulin to overcome that. And fluids also help flush out ketones as well. But again, our ketone dosing is rapid acting insulin, but it's just 10, 15, or 20% of basal insulin for small, moderate, or large ketones. So an example, because I know my voice can put people to sleep. So let's say we have a kid, and I was lazy here. I used a bunch of abbreviations, and I shouldn't have. So I will fault myself for that. So the blood glucose is 225. The kid's going to eat 60 grams of carbs, and they have no ketones. Insulin to carb ratio is 1 unit of insulin for every 10 grams of carbs. Correction factor is 35. The blood glucose target is 120. So how much insulin should this kid receive for their meal and correction? So got 9. All right. Man, you're just firing through this. I love it. Yeah, yeah. All right. So grams of carbohydrate. So y'all know how to do this. So 60 divided by 10 is 6. BG target minus your target correction factor gives you 3. Man, now if I had a candy to give you, I'd give you some candy. Yeah, it's okay. 3 gold stars. So 9 units. All right. Next example, you got a blood sugar here, 425, small ketones. The kid's saying, I'm not feeling hungry. I'm not going to eat. Insulin to carb ratio is the same at 1 to 10. Your correction factor is 35. Your blood sugar target's 120, and your basal insulin is 30 units a day. What we got in there? So y'all know how to do correction insulin dose. So 425, 120, 35. Divided by 35 is 8.7, just round that to 9. And your ketone correct. How much? What's this kid's ketone correction for small ketones? 3. Yeah. So 9 plus 3, 12. Good job. And let's say this kid was made NPO. How often in the hospital would he be getting his blood sugar checked and correction if needed? Every 3 hours or every 4 hours? Every 4 hours. Perfect. Yep. And so then we have an order set for insulin pumps as well. And the start of this order set is pretty much identical to the kids on multi-daily or multi-dose insulin shots. It goes through when to notify for your blood sugars, your ketones, what to do if the kid's eating, not eating, how to transition if they're coming from the drip to their pump. It's all there. We're talking about what, signs and symptoms of hypoglycemia, what to do if they have a low glucagon, consults, the meds are still there, the fluids. The biggest thing here, though, is just when it comes to insulin pumps, every pump is different. Whether they're on an Omnipod, a Tandem is primarily what our patients use. And the settings can change. The settings in the last note might not be what that patient is currently using right now. So a lot of times we'll just have the family getting to their pump and just read out loud what the settings are. If they don't, the last note has settings in it as well, because whatever orders you put into the Epic, it's not going to change that kid's pump. The pump's still going to keep running based on what is in. So we want to have the orders and the pump correct with each other so we know what the kid's getting. But if you're worried like, holy cow, I'm going to mess up that kid's pump, you're not, unless you touch that kid's pump, which you're probably not going to touch anyways. But that's the only way you could do it, if you manually went into the kid's pump and changed stuff around. But when the kids are here on insulin pumps, we have the families help us, with the management of the pump, of, reading, going into their settings, telling us what they are, putting in, carbs into the pumps and all that kind of jazz. And then when you have an insulin pump order set, it does look very different than when they're on shots, because the way that a pump works, remember, is that there is no long-acting insulin with pumps. All pumps are filled with rapid-acting insulin that are just constantly infusing 24 hours a day at some set basal rate. And then the pump still has no idea what the patient's eating, so they have to manually enter in their carbs into the pump, and they have different carb ratios at different times of days. And then we still put in blood sugar targets and correction factors into pumps as well. Now, the pumps are smart. They are really computers that people wear, because they will do the calculations. They will give the insulin. I will say that pumps are smarter than everybody in this room. Maybe not, but they probably are. So when you are going through your pump order set, kind of the first thing that you see is just your insulin to carb coverage. So when you look at a pump, it'll tell you between the hours of midnight and 6 a.m., carb ratio is 6, or, carb ratio is 7. And this is just where you're going to type 1 gram, or you will type in what the carb ratio is. If it's 1 unit of Humalog per every 6 grams of carbohydrates, and you'll type, 12 a.m. to 6 a.m. You just have to type in the specific time points for what their ratios are. Most people using pump have different carb factors at different times of day. Not all, but I'm going to say it would be more unusual for one carb ratio to hold that person all day long. So we just got to type out there. And then the next thing you see is just the correction factor and the targets. A lot of times the pumps, especially our smart pumps, our closed loop hybrids, you're not going to change their target. Like the tandem pump, it's running at 110. You can change the Omnipod. I will correct myself there. You can select what you want it to be at, and you can do different times of day for it. So you can have different targets at different time that you can enter for the time frames here. And then the basal rates is just when you're on a pump, again, it would be unusual to be running the exact same basal rate for 24 hours. So a lot of times midnight to 6 or midnight to 7, they have a particular rate. And then from 7 to noon, they have a rate. And then noon to whatever, you have a rate, because pumps just allow for finer titration of insulin dosing. So this is where we type all those different parameters at. And then at the bottom, we still have what we're doing for ketones if they occur. And the families can bolus off the pump. Now, I will say if you're in the hospital and the kid comes in and they're having hyperglycemia, the nurse helps the family and they give a bolus, and 2 hours later the blood sugar is worse or hasn't changed at all. The infusion set has probably failed on that pump. So that's when you're going to call endocrinology and we're going to say, let's give a shot the old fashioned way and have to change everything out. So just know that the insulin infusion sets can fail. Pumps are tools, they're not perfect. So just, be able to troubleshoot if need be. And then lastly, I just wanted to bring up our smart pumps because more and more kids are transitioning to these because they do such a good job at improving glycemic control. They're not perfect. We're not giving you back an artificial pancreas, but we have more kids using these systems now of where if you'll wear a continuous glucose monitor, they will talk to the pump, and every few minutes they'll be making changes to the basal rates, or if they're staying above target for too long, they'll give a little correction. Typically it's 60% of whatever the true calculation is to kind of help improve people stay in range. But they have to be wearing both for them to work. Like if you take the CGM off, the pump will just resort to manual mode, which is kind of using an old-fashioned pump of just the settings that you saw on that last slide. That's how it's going to be running. Where if you keep them in automatic mode, just every 5 minutes, it'll be making adjustments as it goes. A lot of times we see these pumps really do very well overnight when the kid's asleep and you take a lot of the variables such stress, activity, food out of it. They can dial in and run really tight numbers during that times. Which is really cool. So we're going to see more and more of these kids coming in there. So if you got a kid that has a broken foot that's just going to be admitted overnight, don't go into the ER and take all his technology off of him, because he's going to be better off wearing his technology than going back to insulin shots. And then other things, just quickly, I'm sorry, I'm going too slow here, to reduce error is we've hit a lot of this. We got barcodes that we use at our hospital to make sure that we're using that pin with that particular patient. I mentioned this earlier, all the nurses use 2-person verification to make sure the doses are appropriate. We do have policies in place for insulin pumps and continuous glucose monitors. Our wonderful pharmacists do review orders, and then our inpatient diabetes educators and endocrinologists are all available as well. And with that being said, I thank you for your time and your patience, and I will take any questions, and these are the references for this talk.